Dr. Farrar?
I'm still struggling with the data presented and the risk level patients we're talking about to sort of place in my head where the value added is to doing this within the ED visit, the OBS visit, versus outpatient.
Well, it's a patient who comes in who has, a 20% risk of having an MI, urgent revascularization, or death in 2 weeks. So that's a patient that I wouldn't be comfortable just sending out as an outpatient. But that is a patient that if I had a negative CTA, I would be.
So the
I think
current,
20% risk is too high to send someone home.
yeah, so these are the ones that we're putting on OBS currently and then getting evaluated by
Yeah, those,
cardiology.
I think those are the patients that I hope, like, our gestalt feeling is, this is a patient who we can't let go. We need to stress them before they go.
Yeah.
We need to kind of rule them out. We need
So it's
something
to
more.
replace the stress test.
It can replace the stress test. It can also replace 6 or 8 hour rule out with, an echo that's normal. If I have a patient,
Except that we're saying that we can't do this in 6 or 8 hours. Like, that's why I'm struggling. If this patient's gonna be here for 28
right?
hours anyways, and we're gonna do the repeated troponins, and in my experience, aside from the weekend that we're talking about, we can efficiently get the stress
Yeah, I
test,
think
like,
it's up. I think it's up
where
to
is-
you. I think that. So let's say today is Wednesday. Today's Wednesday. So if I'm covering the OBS unit and I see a patient like this in the morning with a intermediate pretest probability, I might order a stress echo today and get it done, or I might rule them out enzymatically, get a regular echo, see that there's normal wall motion, feel confident sending them out, or I might order a CTA.
I don't think this is a test that the ED doctor should be ordering. I think this should only be ordered in consultation with cardiology. And they should determine, if the stress test's available that day, then that's probably a better option. Or if this is available, I don't think we should be ordering this at all without consultation with cardiology. And I think this is going to be a very small number of patients.
Right.
I don't think this is going to be your average way to rule out patients. This is going to be for a very narrow group. And because if we did order this too many times, we would fill up the CT. And there wouldn't be any strokes, CAT scan, there wouldn't be any PEs, there wouldn't be any trauma. So just for many different reasons, for technical issues, for statistical issues, and for operational issues, this should be a very small number of patients that we do this on.
Yeah, I mean, I think you're right. I think we should definitely start that way. Let's
Right.
strive for a year and see where we're
Yeah.
at.
Yeah. Well, so my understanding is that this is like really only a test for atherosclerotic burden, and so like our cocaine chest painters who are going to be intermediate risk, like we're not looking for anything in those types of patients.
Well, I'm not sure.
The
The
cocaine-
TIMI data is everyone who comes in with chest pain.
I mean, the
Yeah.
cocaine chest pain patients
Yeah.
all have atherosclerotic disease too.
Yeah.
So I don't think you can rule them out that way.
Well, they're young, like 30 something.
The Vietnam War data where they opened up, a tremendous number of young people, the atherosclerotic burden was quite high.
I would trust your scoring system.
Yeah.
Age is one factor in TIMI and in the heart too. So I would look at the big picture.
I think I remember you mentioning also some people who have to 5 that have a normal EKG, a normal negative troponin. Do you think those patients should try and catch also trying to increase the numbers?
I think we should catch those patients.
Just,
Yeah. I mean, what comes out of this, which I think we should all, and which was eye-opening to me and probably to all of us, is how low the event rate is in those low-risk patients. So like Dr. Sinner said, those TIMI 0-1 patients should not be admitted to the hospital. And lean on us for that. We are expanding our outpatient services. Let us make that decision if you're not comfortable. But I'm going to direct my division not to admit those patients.
Right. And they shouldn't be on OBS either.
Right. They should go home.
They should just go home.
Yeah. We're in the midst of creating a 9 to 5 drop-in clinic in cardiology. So as that comes into play, that'll be a patient I'd say sent to our drop-in clinic. And the patients at the high end of the risk, shouldn't be in the ER either. They should be here getting CAF or in the CCU or on the floor.
Right. They shouldn't be in OBS either.
Correct.
Right. They shouldn't be in OBS either.
Yeah. It's really that middle piece, which is the challenge for all of us, and that's the group that needs our tests, so we can send them home or send them to the lab.
But because I think the burden of large vessel coronary artery disease is pretty small in our population. The number of STEMIs per week, at both hospitals, 5 or 6? For 250,000 ED visits a year is a very small number. So I think when you calculate your pretest probability, that fact of the prevalence of large vessel disease. Now, small vessel disease is very common, and CHF is very common, and spilling troponin is very common. So, you know, you have to take that into consideration.
I was given, 2 days ago, I was given our 2014 New York State MI data. So this was way before I got here, you know, before I'm sure a lot of you got here too. But we had 8 mortalities in non-ST elevation MIs and 1 in ST elevation MIs. And, you know, I just want to remind you that the mortality in a non-ST elevation MI is greater than mortality in ST elevation MIs. There's a lot of reasons for that. We can talk about that some other time. But these are patients who are very sick. You know, these are patients that we really need to capture.
To you.
For ED colleagues, let's say we see somebody in the ER who decide to opt, who has like a heart score of say 5, and their TIMI score ends up being a 4. And this is a candidate who would otherwise, before this test, get a stress test or an echo or some type of workup while they're on observation. And let's say you give them this test, this CTA, or this coronary CTA. What findings would you look for on this scan that would make you want to act more vigilant?
Disease. So, you know, proximal LAD lesion, 70% to 90%.
I think what you're doing in this is to look at the ones who are negative. Then
Right.
you just send them home.
Right.
All the other patients probably need to get studied.
Yeah, I mean, if you scan that patient and they have disease, you have to cath them.
Yeah. So this is just, we're just looking for a negative test in the intermediate group. That's the only, positive test doesn't matter. It's the negative test, send them home.
And the benefit,
Definition of negative test in most of the studies is below 50%.
right? Yeah. And the benefit of this test over a cath is there's no big intravascular access, which has complications. Logistically, it should be easier than getting a cath, and there's less contrast.
What about compared to nuclear stress though?
It's the same amount of radiation as nuclear stress. Actually, nuclear stress probably has a little bit more. So nuclear stress is probably like
the post-test.
It's about the same.
about the same.
It's about the same.
About the same.
Yeah.
It seems like almost as involved as in
It can be. I mean, if you have a very well-oiled system, like I was at Lenox Hill where we did, it was great.
Yeah.
But that had to be built, and we'd have to build that kind of
So
system.
potentially, it's easier to do tests.
Potentially, like the data that Dr. Sinner showed, where ER 5 hour. You know,
Right.
yes,
Okay.
it could be, and nights and weekends.
Anyone else? Dr. Jackson?
I was going to say something when you said it, about 50%.
Got it. Great.
So from the observation standpoint, so if a patient is a candidate to, and able to receive the CTA in the future, is that going to like replace like these stress tests?
You know, it could. You know, so there's a cardiologist assigned to the obs unit every day,
Right.
Monday to Friday. So, you know, that.
I'm sure we're going to get your guys' recommendation.
Yeah, it's one of the tools we have. You know, it's a tool we have. There are some patients who you can't stress. And you know, there are some patients who would require a nuclear stress test because they can't walk on a treadmill and they need less to scan. And there are some days where we can't get the nuclear isotope for another day because you need to order it in advance. So in a moderate pretest probability patient where we didn't have a dose, who couldn't walk on a treadmill, this would be a good test. Or if I got a call Friday at 4 o'clock in the afternoon for a patient who fit into this category who we were not going to be able to stress because we don't stress here on weekends, this could be a good test to do.
I
I'd
think
also like to add quickly that presents a problem for radiology, whereas we have techs who are very regular during the week, on the weekends, coverage is definitely squatty, which means that, you know, the skill level of the techs in the weekends is going to be really high.
And I think it's pretty obvious when we're all talking here. I don't think we know exactly where this is going to fall in our protocol. I think part of the point of this is to start trying to figure that out, start the conversation. And I'm glad, I think everyone's on the same page in the panel and speaking about it. It's kind of a cautionary tale too. This is not, we shouldn't show up when this opens up first day and everyone should be getting coronary CTAs.
Yeah,
So,
you know,
it's-
create a pathway together, start slowly and see what we do well and see where we need to improve it.
It's a specific patient population that it's valuable in, specific patient population that should get it, that's safe for. So I think we don't know exactly where it's going to fit in, so we'll find that out.
Which beta blocker would you use? Does it matter? Metoprolol?
Using metoprolol, there's
Short acting.
There's a bunch of algorithms. Usually you'll start with an oral metoprolol dose half an hour before the scan.
Okay.
And then if the heart rate's not lower, you might give 5 IV before.
Okay.
Any other questions or comments? Dr.
Just
Xavier?
for a pause, from a clear perspective,
obviously this is not implemented yet, so any residents who are looking for a pilot project are interested, reach out to Dr. Jackson. We are going to be working on getting some of these guidelines and protocols in place, and you know, that's all.
And it'd be really interesting to see what happens if we really stick with this TIMI 3-4 risk group, because the other trials, as you said, really have patients with much too low of a pretest probability to make this worthwhile. We'd be the first to really zero in on that ideal patient population.
All right,
And
guys.
just so you know, just shout out to Bonnie who's actively working on the ops curriculum to add this piece in for your guys' education. Coronary CTA in observation is very common right now. It's actually within with NYU does it, Mount Sinai does it, there's a lot of other institutions that are doing it. We have reached out to them, we have their protocols, we have their feedback, and this is something that we're going to definitely be adding in the curriculum for continued education. Okay?
Dr. Gillespie?
This isn't an accusation or anything, but for the 3s and the 4s, so usually run the odds unit. Obviously, this is just your own estimation. What percentage do you think of patients that we get admitted or go into observation are these 0, 1, 2 risk factors, or 0, 1, 2 TIMIs versus maybe 3, 4s? Like, I mean, this would just be a ballpark. I know you haven't studied this. 65, 6, 1, 2s? Yeah.
Really, it shouldn't be that.
Yeah, I'd say 40%.
Yeah, and again, I think that's why we should start having this hard kind of.
Can I just follow up that? Just kind of based on that right there, it sounds like our problems could be solved by just kind of not even using the coronary CTA.
Right, just using a TIMI risk or the heart risk. Yeah, absolutely. And you know, the cardiology is there, so you should lean on us for that. And I love discharging patients.
And you know, there is a guideline already published that we wrote 5 years ago that TIMI 0, 1, and 2, chest pain less than 6 hours, 1 troponin at home.
Yeah.
And there's a new
That is the protocol.
Uses the heart score that does the same.
Yeah, look at the new chest pain ops protocol. It's very clear. It says heart score 0 to 2 or 3, just discharge to cardiopulmonary problems.
Yeah.
Unless there's something else concerning the story, but yeah.
Try to do it on Monday, 7 to 3 before I get there.
We have time for one more comment. I'm sorry, Eric. I'm going to supersede you with Dr. Silverberg.
Is that even valid to the new troponin that we have?
It's not the new troponin. The troponin T, it's the same thing.
Any cardiac biomarker.
Eric, do you have a question?
Just like, that would be more applicable to all the attendings.
Well, unfortunately, we're going to end on that note. So thank you.